Hi, Assalamu alaikum. Thank you so much for this kind invitation. It's a pleasure to be with you today. So today I'm going to present some advices about things which possibly we need to avoid in challenging glaucoma scenarios. So actually, before we start, the problem with the glaucoma, we have, let's say, few issues. First of all, glaucoma can easily mimic other pathology. As you can tell, we need always to think about other pathology. So that's one challenge. The other challenge, it is a silent disease from the patient point of view, and it's mysterious disease from the patient point of view. So we have to educate the patient about this. Third challenge, symptoms actually start from the patient point of view after we start them on the treatment, not before. So they come to you without symptoms. We create problem. We create redness. We create issues related to the ocular surface. And lastly, if we go and suggest surgery for the patient, then we create even more blurry vision. So as you can tell, this combination is not ideal. And this patient in front of you, you have to deal with them in a very special way. It's not like any other disease you are dealing with. So some advices, and you may find some of them very straightforward, it's just reminder, and others may be slightly related to other experience. So do not suppose all suspicious optic disc or field defect are glaucoma related, and that's something, I think it's a common sense. We all know we need always to check RAPD as a routine color vision and color of optic disc, and we always need to check the pattern of the visual field defect. And we need to combine this with the anatomy. Does it fit or not? For example, if we see something like this, where the patient has inferior notch, and then obviously on the top they have visual field defect, that's glaucoma related. But if we see like pale optic disc like this with this type of field of vision, that's not glaucoma related. From my point of view, I'm very big fan of the ganglion cell layer analysis. So I always try to combine the things together. As you can tell with the Heidelberg, with the glaucoma premium module, you can always check the residual ganglion cell layer. And in this case, the residual bit is in the upper part in both eyes, respecting the horizontal midline. And that's why you expect superior visual field defect. And if you go and do the ganglion cell layer analysis, in other case, you see it's respecting vertical midline, and it is neurological. Other things, if you have unilateral progressive normal tension glaucoma, this is not supposed to be before you do a lot of investigation. You always need to request MRI scan with contrast. You always to do 24 hours blood pressure, and to exclude dip in the blood pressure in the evening, which could mimic glaucoma. You need to check bloods, mainly full blood count, B12, folate, vitamin D, A, ESR, CRP. And lastly, you need to consider other differential diagnosis. This is so important. I wouldn't at all diagnose unilateral normal tension glaucoma in any case, unless if I do these cases. This is again one of my favorite slides. Do not delay the appropriate surgical decision. This is the worst thing to do, because as you can tell, the glaucoma, for example, has two types. The dot line is the one which is benign type. We call it with a slow progression. This patient will never had a problem during their lifetime. And we have the invasive one. With the invasive one, which is the straight, not the dot one, the one which is dipping down. If you operate early, you can save the vision. If you operate late, you will still have visual problem during the lifetime of the patients. Do not delay the decision. Do not do filtering surgery before building trust with the patient, not from the very first moment. This is a big surgery, as we said, and you may expose this patient to reduced vision. You need to discuss about the complication, including wipe out in advanced cases. You need to ask about social support and the use of the drops. Can they use it or not? And obviously, you need to set your target IOP. What is your target IOP? Not every patient needs surgery, even if they have high pressure, unless if you set your target IOP, you won't be able to tell. Cases like this, again, with the pre-op, I can't do trap like this. It's impossible. This is a patient with orbitopathy related to Lumigan, so I won't be able to do with the very tight orbit. I wouldn't even consider trabeculectomy for this patient, because I can't do proper massaging or proper removal of the stitches after. And I always do this movement of the conj using the cotton bud to make sure I have a mobile conj and significant thickness. With the alpha-GAN, obviously, alpha-GAN can cause a lot of thinning of the conj, and that's why you have to always make sure patient on alpha-GAN, they don't have very thin conj. Do not do filtering surgery before calming down the eye. We have to stop the toxic agent. I hate brimonidine, aproclonidine, pilocarpine, bimatoprost. These to me are a no-no ones. And then obviously, in fact, stopping the inflammation itself, it can reduce the pressure. And then my advice, always try to stop everything and start the patient on Diamox before surgery for 4 weeks if you can, to calm down the ocular surface. Try to use topical steroids. Even sometimes I give subconj dex on the slit lamp before the surgery. Cyclosporine could be a one. Consider preservative-free. Doxycycline is my favorite in inflamed eye. It works really nicely. And at least 4 weeks before the surgery. And this is a big evidence that if you operate on an inflamed eye, there are twice the amount of inflammation you get. And lastly, I just wanted to show the last slide, but it wasn't possible. I wouldn't, if I'm doing cataract surgery, I try always not to do it together. That's my favorite, unless if this is elderly patient. I don't do toric IOL for glaucoma patient because toric IOL can cause more contrast and glare. And patient with glaucoma, they always have contrast and reduced contrast and glare because of the dryness and because of their disease. So I try to avoid multifocal if needed. Thank you so much. Thank you.